Before we start second day of the conference today, I would like to inform the audience rules of today's conference. Number one, participants are requested to wear formal, polite clothing while attending the webinar. Participants write their real name on Zoom application and are requested not to use the device name. If the committee does not recognize the participant identity or does not match what is recorded in the registration form, the committee has the right to remove the participant from the application. When delivering the material, microphone in Zoom application should be deactivated and video allowed to be turned off as needed. Participants are requested to activate the video from beginning until the end of the session. Oke, saya akan mengulangi hal-hal penting dalam kegiatan konferensi internasional hari ini adalah yang pertama, partisipan diwajibkan untuk menggunakan pakaian yang sopan selama menghadiri kegiatan ini. Kemudian harus menuliskan nama asli yang sesuai dengan yang telah didaftarkan pada form pendaftaran. Kemudian apabila pada saat pelaksanaan seminar ditemukan adanya nama yang tidak sesuai, maka dari panitia berhak untuk mengeluarkan dari kegiatan seminar ini. Para peserta juga diwajibkan untuk menonaktifkan mikrofon selama kegiatan berlangsung. Kemudian semua partisipan diwajibkan untuk mengaktifkan video dimulai dari awal sampai selesai kegiatan ini. Terima kasih. Excellencies, distinguished guests, participants, ladies and gentlemen, in the second day of CMFI International Seminars today, I would like to introduce and welcome our guests and presenters today. The first is Mr. Po-Ching Huang, MPT from National Cheng Huang University, Taiwan. Good morning, Mrs. Po-Ching Huang.
Hello, can you hear me?
Yes, yes.
Okay, great.
Okay. And Mr. Dimas Sondang Irawan, SST FTM FIS from UMM Malang. Selamat pagi, Mas Dimas.
Selamat pagi, Mbak Nina.
Oke, sehat, Mas?
Alhamdulillah, sehat.
And also, we welcome all the participants of CMFI International Conference today. Thank you very much for your coming on second day first CMFI International Seminars 2020. Today, we will hold a discussion with two speakers. Ladies and gentlemen, now we will continue to the next session. Before we move further to the next agenda, the technical committee would like to thank to our general sponsor, Aisyah Yogyakarta University, Muhammadiyah University Malang, Widya Husada University, and PT Karya. Ladies and gentlemen, without further ado, now me welcome our speaker, Mrs. Po-Ching Huang, MPT from National Cheng Kung University, Taiwan. The speaker will be moderated by Mr. Rahmat Rosadi, SSTFT MSCPT. The session will be last about 1 hour and 30 minutes. For Mr. Rahmat, please come join to open the session. Thank you.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Everyone hear me?
Yes.
It's clear enough, my voice?
Yes, enough.
Okay. Okay, good morning, Rahel. Morning, Rahel. Hello, Rahel.
Hello.
Can you hear me?
Yes, I can.
Okay. Good morning. Okay, welcome to Indonesia again, even we are in the webinar. So today, in this second day, we will like to, the speakers will be explain more about the COVID-19, after COVID-19, but we have the change of the title, right? So on the information before you You get the information from the pamphlet. The information is about the more about the ventilators. But 2 days or 3 days ago, the authors have mentioned to me that we changed the title, physical rehabilitation of COVID-19. So I think the physical rehabilitation or physiotherapy treatment or physiotherapy intervention after COVID-19 is most interesting point for this moment, right after the pandemic around a whole year. So just a little information for you, Po-Ching, Huang. In Indonesia, COVID-19 is still high number. 2 days or 3 days ago, the positive for the COVID-19 is around 5,000, 5,400 or 5,100. So this is quite high numbers in Indonesia. And for you all participants, compared with the Taiwan, if I'm not mistaken, the last uh, local transmissions, if I'm not mistaken, the last local transmissions in Taiwan during April, if I'm not mistaken. It means during past 7 months, there is no local transmissions in Taiwan. So I don't want to talk more about the how the government take care with the pandemic issue. But today we have already one speaker that she is very expert in the cardiopulmonary and the physical therapy fields. I don't want to mention everything about the Po-Ching Huang. You just write down her name in the Google searching. Everything will done. All the articles, what she's done, everything this just came up in your laptop. So Po-Ching Huang, we have 1 hours. So after 1 hour, we have Q&A sessions. So all the screens start now. This is yours.
Okay. Okay, so can everyone see my PPT?
Yes, clear.
Okay, so, let's start today. Okay, so good morning, everyone. Today's our topic is about the newest infectious disease caused by the new coronavirus, which is COVID-19, and how the physical therapy could help the patient who underwent such a disease to return to their normal life. And we also will talk about how the physicians could protect themselves during the practicing of the intervention. And in the third part, I'd like to give a little attention on the disease prevention. And hopefully today's
Excuse me.
Yep.
Okay. Just go ahead because just unmute, I think.
Okay.
Go ahead.
Okay, so I just try to help you to understand the disease and to know how to practicing the pulmonary rehabilitation on this kind of the patient. And the most important thing is to keep yourself safe during the practicing. Okay. Okay, so here's the outline. The first, we were going to introduce the disease, and we were going to introduce the route of transmission and its symptoms and the disease. Wait a minute. Let me switch this. Okay, and the second part we're going to talk about is the PT intervention for the COVID-19, including the medical, wait, how do I change this? Okay, the second part is we're going to introduce the PT intervention, including for the hospitalization during the recovery phase and the quarantine phase. And the third part, we're going to talk about the prevention of the COVID-19. Okay, so the first one, the COVID-19, it is a severe acute respiratory syndrome, coronavirus 2. And now it's a new virus that emerged in 2019. So the names COVID-19 has been arisen. And with a little knowledge about this disease, all the management and the caring strategy will provide based on the scared and direct and indirect evidence and the observation and the experience of the clinician around the world who works hard against these kinds of disease. So all the suggestions here should be revised or revisited as the evidence accumulate to ensure that the suitable of our management. Okay, so the first one we're going to talk about the route of transmission of the COVID-19. It is transmitted from human to human, and it is very, very high contagious. So it was transmitted through the respiratory secretion, including a cough or sneeze or the runny nose. We call the airborne particles that will it will have the virus inside this like our savella of our sputum. And when this kinds of secretion is exposed into the air, it is highly contagious to the human. Okay, so here, when someone is coughing and he doesn't wear a mask, the aerosol airborne infection particle will remain viable in the air at least for 3 hours. And then it will be inhaled by another person who didn't wear a mask too, or it will land on someone's mucosa membranes of eyes. But we know that the COVID-19 virus is highly contagious on the mucosa structures. So they're not just the eyes, but also the nose. If you inhale the air particle, it was also likely to be infection. So when you have this kind of problem, you got the COVID-19 really quickly. And the second episode is that when someone is infected of coronavirus and she didn't wear a mask and she had a cough, and the virus could last on the surface for 24 hours and then transfer through someone's hands touching on a contaminated surface. And then you touch your mouth, your nose, or your eyes, then also you will get the COVID-19. Okay, and the symptoms of the disease, most of the confirmed diagnosis, they had the symptoms of fever. It had 89% of the patient who has these kinds of symptoms. And 68% of patients, it have the cough symptoms. And then there are more and more evidence accumulate that the patient will suffer from the smell and the taste loss. This is now the more evidence has shown this. And also some patients will undergo fatigue and the sputum production and short of breath. So we could see, except of these symptoms, most of the symptom is more like just having a fever. So for the COVID-19, actually is if you are infected, if you are healthy, you don't have any other medical condition of your body. Actually, you just underwent like you have a serious fever. And the average incubation period was to 5 to 6 days, but it could last as long as the 14 days. So that's why we set up the quarantine days for 14 days. Just for the patient to show their symptoms and for us to understand, to see if there are some others, if patients are really infected or not. Okay, so here is a spectrum of the disease severity. And we can see here under 80%, about 80% of patients, they are just a sympathetic infection, or they just have the mild respiratory symptoms, just mild symptoms, like we mentioned before, to the mild pneumonia, which is actually you could just take a rest and the symptom will ease. However, they will have 15% of patients, they will have the severe viral pneumonia with a respiratory failure. And they might have the dyspnea or hypoxia or more than 50% of lung involvement on the image, and they will require oxygen treatment. And then they will have 5% of patients who will turn into a critical ill. They will have the respiratory failure, the shock or multi-organ system dysfunction, and they will require the ventilation and the life support. And for the patient who might have the critical ill, it was next PPT. Okay. Okay, so there are some factors associated with the worsened outcome. And the first one is the increasing age. The increasing age is the evidence showing that for the elder or the male, they have a higher severity levels to have a worse prognosis of this disease. And the second one, is the comorbidity disease. The comorbidity is the presence of one or more additional conditions co-occur with a primary condition. It included diabetic or cardiovascular disease, including hypertension, and also some others problem like, wait, can I move this? Okay, some other problems like hypertension and also some other chronic lung disease, like if the patient has the COPD, it might also worsen his outcome. And the third one is the coagulopathy problems. Coagulopathy is the problem that it will affect the blood ability to form a clot that is impaired. So if patient has this kinds of problem, it might also affect the prognosis. And then the next one is the higher illness score. It means the higher admission sequential organ value assessment, which we call SOFA scale. If patient has lower of this scale, it will also affect the outcome. And the last one is laboratory abnormalities. With the laboratory some parameters data, if patient has the elevate of the D dimer, elevate the D dimer, or the lactate dehydrogenases. The lactate dehydrogenases is an enzyme that found in nearly all the living organs. Or the ferritin. The ferritin is a universal intracellular protein that will store iron. So it's in our blood. It was related to the ability to carry iron in our blood. And also if the elevate troponin. A troponin is the protein in the muscle tissue that involved with the muscle contraction. And then also the thrombocytopenia. Thrombocytopenia is a condition categorized by the abnormal lower level of the platelets. So it is sort of like that we call the coagulopathy problems. And also the neutrophilia. The neutrophilia is a leukocytosis of the neutrophils, that is the higher number of the neutrophil in the blood. So we could see in all these factors, they are more likely to coexist on the elder. So that's why for the elder, it is much more fatal to get the COVID-19. Okay. So for the diagnosis of the COVID-19, now the most standard diagnosis we use is the RT-PCR, which is the real-time PCR. The real-time PCR is that we collect the specimen and use the PCR technique to replicate the RNA sequence of the virus and enlarge the signal to identify the presence of the certain virus. It will take half a day to get the results, and its advantage is the method has a good sensitivity and specificity. The precise rate is more than 90%, and with low false negative results. However, the disadvantage of this kind of test is that it costs a lot, and also it needs the higher standard of the equipment, and also it needs the technician to operate. And the second one is we use the COVID-19 test kits. This kit is used to detect the antibody of IgG and IgM in the serum, and IgM will present after 1 or 2 weeks after the infection, and with the virus decreasing, the human body will start to form the antibody of IgG, which could last for months. So if the results show the IgG in the results column here, if it shows of IgM, it means that the patient was at the beginning of the infection. And if it shows of the IgG, that means the patient was at the final stage of the infection or just already going to the recovery phase. And so if the results shows both IgG and IgM, it means the patient was confirmed diagnosis and was during a highly contagious phase. So for this kinds of patient, you really have to take care of yourself. So when a patient comes to have the COVID-19 test, we have to consider the patient was at a highly contagious phase. So make sure you have protect yourself enough to before you contact to the patient. Okay, and here we talk about the case shouldn't be avoided. The first one is the subcutaneous incubation, or the bronchoscopy, or the pulmonary function test, or the spirometry. In all these kinds of the test, it has a highly risk of contagious. For it is easily for the operator to access to the patient's saliva, which will be which is a source of the infection. So for all these tests, I recommended this should be avoided, or this kinds of the like pulmonary test is, although it could provide us lots of information, but still it has to be it has to be avoided, will be better during this phase. Okay, so we're going to this part is we talks about physical therapy for the COVID-19. So COVID-19, it will leave a lot of dead cell, the damaged tissue, and the fluid in the lungs as the result of the intense immunoactivation that often occurs in the response to the virus. However, once the infection is gone, the lung will start to rebuild and create the new cells to replace the dead one. And it will promote the refresh of the lung tissue. And if it could not happen, the scar will form on our lung surface, and some of them will be permanent. And the research on COVID-19's lung recovery is still in early stage, and just offer a limited pictures of what the recovery from the disease may look like. But scientists really need a couple of years of data to build up the evidence base. But so far, we are still conducting the PR following the change we already know. And most importantly, we have to keep our information updated so the research evidence is refreshing every second, and we could give a patient a proper treatment to improve their abilities. Okay, so first one here is an article. Lately, they just having a ERS, the European Respiratory Society, they just have an international conference, talks about the PR of the COVID-19. And this is one of the conference article. In this article, they have recruited 19 subject who was post-intubation before admitted to their PR clinic. And the patient, their average hospitalization days is 24 days in the ICU and 34 days in the pulmonary ward. And they use a 6-minute walking test to test for the exercise capacity. And then record patient's 6 minutes walking distance, the oxygen saturation response, and the heart rate and the dyspnea. And the results showing after the average 21 days of PR program, the 6-minute walking distance has a huge increasement. And also the patient during the test, the patient is underwent a severe desaturation. However, there are no dyspnea reported. And they have finding out that with the longer delays of exacerbation, from the exacerbation to the PR program, it is highly corrected significantly to the lower improvement of the distance. So in this article, in this research, they have suggesting that the PR program for the post-COVID-19 patient was important, and if the sooner and the longer will result in a better prognosis. And this is the other conference paper which presented on the ERS conference. And in this article, they have conduct about 190 patients, and they have given them the examination to see their lung damage after the COVID-19. And the test time point was set up after 6 weeks of diagnosis and after 12 weeks of diagnosis. And the lung damage from the inflammation and the coronavirus induced the fluid accumulation, which we could see like a ground glass patching on the X-ray. And at 6 weeks, there are 88% of patients. However, at 12 weeks, there are only 56% of patients. And the severity of overall lung damage is from the 8 points down to the 4 points. And the forced expiratory value in 1 second is lower than 80%. At 6 weeks, there are 23% of patients, and at 12 weeks, they are down to the 21%. And the forced vital capacity lower than 80%. At 6 weeks, there are 28% of patients. However, to the 12 week, there are 90% of patients. And there are no signs of progressive pulmonary fibrosis was observed in any patients. So according to all these results in this research, the author has concluded that the data suggesting that COVID-19 will have the lung damage. However, it might be reversible, but the time will cost more than 12 weeks. So according to all these results, we know that after COVID-19, the lung will surely have some damage. However, the damage is reversible, but it might cost more than 12 weeks, that is 3 months. And even after 3 months, some patient, the lung function was still lower than when he get a disease. So if it's possible for the patient to recover his lung ability back to normal, it is still under observation. However, we could help the patient to regain their pulmonary function through the rehabilitation. So that's why our physical therapy to help during the COVID-19 and also help the patient to return to their normal life more rapidly. So the first one we're going to introduce is what we can do during the hospitalization. And we could do is, the first one is the respiratory support. We would try to provide the patient the breathing control, the thoracic expansion exercise, the airway collections technique, and also the respiratory muscle strength training. And also we were trying to give to teach the patient to have more mobilization exercise, like they could have some bed mobility activity and active RM exercise and ADL training and transverse training. And if the patient has a better exercise capacity, then the psychoergometry is also applicable, and also pre-gaze exercise and ambulation will also be recommended. So the early mobilization we suggest in patient we could do. The mobilization, it means the goal defining as the physical activity that perform with the proper intensity and will produce the physiological benefits of the bodies. And early mobilization, it will means the activity that carry out from the beginning of the stable physiological status, and it will continue during the ICU states. It includes the activity that will produce the movement, such as the active limb exercise, or moving on the bed, or sitting on the edge of the bed, which will acting on the circulation, the central and the peripheral perfusion, the ventilation, or the states of the conscious. Okay, so treatment strategy here, the first one we talked about, we could have some postural change. The postural change could reduce the occurrence of the bed sores and promote the sputum excretion, and also reduce the degrees of dyspnea. And avoidance of the bed temperature is important because it will help the patient to generate the activity levels, and also it will help their sputum discharge. So the half seat, like a 40 to 60 degrees, or the sitting position are promoting whenever it is possible. And if the patient is unable to sit independently, we could adjust the bed angle to rise between 30 to 40 degrees, and the postural intervention should be performed 3 times per day and for at least 20 minutes per time to help the patient to adapt to the postural change, and also be aware of the postural hypotension. If the patient has bedridden for a long time, it is better we increase the elevated degrees gradually. And the second one we talked about is the prone position ventilation or the drainage. So many severe COVID-19 patients are ideal for the prone posture ventilation. The prone posture ventilation could have a positive impact on the oxygen binding and the pulmonary dynamics. It is recommended as a routine strategy for patients with their partial pressure of carbon dioxide divided the friction of inspiratory O2, which it is here. And if the patient is on the ventilator, you could find this index on the machine. So if the patient this index is lower than 150 millimeter of the mercury, then the patient is suitable to have the prone position ventilation, which will help his oxygen binding. And we have to keep in mind that we have to stop this kind of ventilation when the patient's oxygenetic index, which is this index is greater than 150%, or their PEEP, the positive and expiratory pressure is less or equal to 10 centimeter, or the friction of oxygen concentration in the inhaled air is less than or equal to 60%. If the patient is have this kind of the parameter abnormalities, it is better we stop this kind of the ventilation posture. Okay, and the third one is the respiratory control. We use the partially breathing. The partially breathing is performing in the sitting or a semi-recumbent position, which the patient's accessory muscle of the inspiratory are totally relaxed, especially in their upper limbs and their neck. And we will teach patients to establish a slow and stable breathing. And these models could be adopted during the rest of the exercise. And I will teach this, I will thoroughly explain how to perform this exercise later. And the fourth one is the physiological activity training, including the standing and the ambulation. So it also includes a bedside standing training in patients with their lower limbs muscle strength of greater than grade 3, or the walking exercise with the patient is standing independently with less help. So maintain the physical strength and exercise endurance, because when the patient is autonomic, we have to conduct this when the patient's autonomic consensus is adequate and they're in a relative stable status. And if the patient's activity level is higher, we could use a bicycle in the bed or just around the bedside, ask the patient to walking or to transfer from the bed to chair. It is a more higher intensity of physical activity when patient is staying in the ICU, and they could perform to try to improve their physical activity levels. But there are also some precautions when we're trying to conduct this kind of movement for the patient. The first one is we always keep in mind that the vital sign monitoring has to be stable, like the ECG, or the oxygen saturation, or the mean arterial pressures, or other vital signs must be monitoring throughout her whole PR programs. And the second one is the maintenance of oxygen levels. The SpO2 should be maintained at 95 to 100% levels of oxygen. But if the patient is at risk of hypercapnia, which is a condition of the abnormal elevation of the carbon dioxide level in the blood, like if the patient is coexist with COPD, the oxygen saturation level could be accepted to keep at 88 to 89%. And the third one is the intensive respiratory training is not suggesting. In this part is because that the patient, in order to avoid the exacerbation of the respiratory load caused by some PT treatment, it is recommended not to carry out the extensive intensive respiratory training, such as the respiratory endurance training, the thoracic traction, the excessive intensive training or respiratory muscle strength. In this stage, the patient's respiratory function is still undergoing the highly immunos changes, and it is highly unstable. So during this phase, please don't give your patient a too aggressive training. We're just trying to maintain their ability. However, we are not training their ability to a next level. So in this part, the training should be focusing on the maintenance, but not improvements. And also we have to keep in mind when to start our treatment and when to stop our treatment. In here, we will start our treatment when patient is at a stable vital sign, or he doesn't have any fever, his body temperature was lower than 37.5 degrees. And when to terminate is that when patient is showing the unstable vital sign, or his SpO2 is dropped more than 4% from the baseline, or his respiratory rate is increasing, or it's more than 30 breathing in a minute, or his mean arterial pressure is changed more than 20% from the baseline from the beginning of the treatment. And if the patient is anxiety or fatigue or have some other physical activity intolerance, then in all of these kinds of the condition, we are suggesting you to terminate the PR program. Okay, so the second part is during the recovery phase. So if the patient is getting better, if it is discharged from the ICU and returning to the normal ward, then in this part we could start to conduct some physical activity training. And before the training, it is important to know the patient's physical capacity assessment. However, we have talked about lots of the testing were not recommended because it has the risk of the contagious. So what can we do? What's the easy part? So of course, the standard test is to have a cardiopulmonary exercise test we call CPAT. It is a standard test to understand a patient's physical capacity. However, a CPAT is also it costs a lot, and it is a test that will challenge the patient's to his limitation of his physical capacity. So if the patient was still weak, the patient is still weak, this kind of the testing might not be appropriate. So they will also have an alternative testing, which is the 6-minute walking test. The 6-minute walking test has been proved that it has a moderate to strong correlation to the CPAT result, and the result was able to predict the anaerobic threshold obtained from the CPAT. The anaerobic threshold is a marker for the combined efficiency of the lung, the heart, and the circulation, and marks the onset of anaerobic metabolism, which is a result of inadequate oxygen delivered. It provides information of the exercise of the patient's exercise capacity. So if the patient is going into the anaerobic metabolism, it means that a patient is starting using oxygen in the wrong way. So it means the exercise intensity is too high for the patient. So we use a 6-minute walking test to understand the patient's level of to understand the patient's physiological levels, and it will help us to providing the proper exercise to the patients to regain his pulmonary function. So here there's an article, you use a 6-minute walking test on a COVID-19 patient, and it made some modification suggestion for us to conduct this kind of testing and to understand your patient's limitation. The first one is it talks about the timing to apply this kind of the testing. The timing they suggest is we could perform the 6-minute walking test at the 4th or the 5 days of the critical illness. That is, if the patient is discharged from the ICU for about like 1 week, then it's a time we could conduct the 6-minute walking test to know the patient's physical abilities. And the second one, the inclusion criteria here, they suggest in the patient if it is older than 70 years old or the pregnant woman should be excluded from this kind of the test because it's still challenge of their physical capacity. And for this kind of patient, they might have some other risk factor we have to consider. So it is not suitable for them to have this kind of the test. And also during the test, the present of the physician is mandatory, and also wearing a mask is also mandatory, highly suggested. And the define of the abnormality is that a single cutoff point of the distance walking lower than 140 feet, or the SpO2 is falling below the 90%. And we really talks about the distance here. So the results of 6-minute walking distance, we have 2 cut points. The first one is the, oh, sorry, here I mistyped. This should be the feet. The first one is the 1,040 feet, and the other cutoff point is 1,080 feet, approximately. So if the patient, the walking distance is lower than 1,040 feet, the patient definitely needs the higher level of caring. So if the patient is discharged from the ICU, however, his walking distance is still lower, so we have to focusing on the some others physical training that is not included the ambulation, the walking, because the patient's pulmonary function level was still not enough to have these kinds of levels of training. And if the patient, the results is higher than more than 1,080 feet, the patient is sufficiently exercise capacity to start a PR program, and they are capable to have the walk or the ambulation program. Even we could improve to a more higher level, like you can have the moderate intensities of PR, like for the cycling. It could we can increase some loading of the cycling, or we could have ask the patient to walk on the treadmill more fast to pursue for more pulmonary training. And however, in this part, this is a blurred zone. If the patient's results is the patient's walking distance is between 140 feet to 180 feet, the patient might need to change to a higher
Rahel? Hello, Rahel. Hello, Rahel. Dengan kondisi COVID di rumah sakit. Dan yang kedua, ada paparan yang sangat sangat unik dari pemateri. Tunggu sebentar, saya ada message dari pematerinya.